Hi, my name is Courtney. I'm the Director of Tapestries for United Methodist Communities at Pittman. Tapestries is our memory support community. I am a social worker by background, and I have a lot of experience in dementia and senior care, traumatic brain injury, education, mental health, basically just a lot of things brain related. And I have a real passion for this, and both based on my personal and my professional experience with dementia. And so I hope to be able to use that passion to pass on some helpful information to you. I do apologize. Typically, these meetings are live so that you have the opportunity to participate and ask questions. However, right now I am on maternity leave. And so I had to pre-record so that I could continue to offer the support even through my absence. I do have some contact information at the end so that if you have any follow-up questions, you still have options for support. And I do want to apologize in advance as well. I've got two children sitting up in my rib cage right now, and so I may get short-winded here and there throughout the presentation, so please bear with me. That said, today we're talking about preparing for medical needs and decision-making. Often we tend to focus in these meetings specifically on dementia, but realistically, as our loved ones get older, they're more likely to have health needs and medical needs that arise as well. And dementia might not be directly related to those needs, but it often complicates how we handle them. And as such, the more prepared we are, the better an understanding we have of, what things we need to be thinking about, the more in control we can feel at a time that's really stressful. So hopefully today's presentation helps prepare you for that. So to that end, we need to think about, what does preparedness look like? This is a very personal process. Some of us are the type of people that have binders and lists and plans for everything. Some of us are the, it'll be fine, fly by the seat of your pants kind of people. And most of us tend to fall someplace in the middle. And none of that is wrong. It's all about what works for you, what works for your family. And, if it works, it works. So, these are just suggestions that you can adapt or incorporate as feels right to you, so that whatever your strategy is, you're ready when something does happen. So first and foremost, what we want to consider is involving our loved one with dementia in the process of decision making whenever possible. Sometimes for some people, what happens is, as soon as they get the dementia diagnosis, there is a belief that they can no longer make their decisions. And for people in the really early stages, that's just not true. And then other times there is, a desire to hold on to who our parent once was. And so we keep involving them in decision-making long after they're not really able to participate effectively in that process anymore. And we just stress them out. And that's not great either. So the idea is that as soon as possible, regardless of where our loved one is, we want to have, preferably in those early stages, we want to have as in-depth a conversation as we can, even if it might be uncomfortable, about their wants for their health, for their medical journey, for any potential complications that might arise, and seek their feedback. If we are already at a point where that conversation is not possible with our loved one, then we want to think about who they were and what they would have wanted at a time when they were able to make that decision, so that we're still acting in their best interests and in accordance with their preferences, even when they're no longer able to verbalize those. We definitely want to consider some legal documentation. Unfortunately, as our loved one's capacity to make decisions changes, they need help to do that. And for the sake of preventing bigger complications down the line, it's helpful to have some things in place. So this is by no means an exhaustive list, but some of the most common ones that we see are a POLST, which is a physician's order for life-saving treatment. We'll talk about all of these in a little more depth further on. Advanced directives, which make stipulations for healthcare wishes when our loved one is incapacitated or unresponsive, that sort of thing. And power of attorney, which can be dedicated to specific areas, like specifically medical, specifically financial, that sort of thing, or a blanket power of attorney. And there's some limitations involved in that as well, but it does entitle you to be involved in the process, to have access to information, and to make decisions when your loved one can't. We want to make sure that we are aware of emergency care options and what getting emergency care means and what we need to have to facilitate that. We want to be prepared for invasive procedures like surgery or even some medical testings, mammograms, colonoscopies, those sorts of things. And realistically, we also want to be prepared for end of life planning. And so we're going to talk about each of those areas today. So proactive planning. This is, things are good, mom or dad is healthy. How do we get ahead of the game? So first and foremost, again, we want to be prepared for some potentially uncomfortable conversations. I know in my family, my grandparents, prior to my grandmother getting dementia, were very focused on end of life planning. And you could not go to their house without them handing you a pad of Post-its and saying, here, put a Post-it note on anything that you want when we die. And they were just very upfront about it, which was mortifying for the rest of us. But they did the same thing with a lot of medical stuff, and it ended up being very helpful in the, in the end when it did come time for them to pass. Sometimes we're the ones that want to have those conversations so that we can honor our loved ones' wishes, and they don't want to think about it because they don't want to think about what life is going to look like when their life is over. They won't want to think about what comes next. Or they view it as like not a problem for them because they'll be gone. That's sometimes the case too. So regardless of what that challenge is, we have to be prepared to say, like, no, this is necessary and we've got to do it. So some of those uncomfortable conversations might be, what type of care do you want during your life? Especially if we're in the early stages of dementia, we might have to talk about the realities of incorporating in-home care at some point. The reality of considering, community placement like ours, or even nursing home placement at some point, because depending on how long they live, the nature of dementia means that unless you are already a medically trained professional, there will come a point where your loved one's needs exceed your ability to safely care for. And if they have the mentality of like, no, I'm staying home and you're going to have to figure it out, that puts you in an impossible situation, and it puts them in a really dangerous one. What type of care do you want at the end of your life? So at the point that we know they're getting ready to pass, because, sometimes we can tell ahead of time, what do they want to help keep them comfortable? What do they want to help keep them calm? How do they want to pass with dignity? And what does passing with dignity mean to them? And that may be very different from person to person. We also want to think about, what do you want after your death? What do you want your funeral arrangements to look like? What do you want done with your body? Who do you want there? Anything in particular? Those types of things are really important to a lot of people. And who do you want to be responsible for decisions when you can't be? This is especially if there are multiple children, if you have a lot of brothers and sisters or a lot of close family members that are all involved. This can be a really awkward conversation, but you want to consider establishing a hierarchy. That sounds bad. If you're, let's say mom has dementia and she had 4 children, And all four of you love and care for her. All four of you have been there her entire, for your entire lives. And that's wonderful and phenomenal that you're also involved. But one of you should be the leader. And that's a hard thing to talk about. That's not to say that the rest of you aren't equally involved and capable and, smart or, whatever. But unfortunately, for every family that completely agrees on what's best for mom in these end of life situations or in these medically stressful situations, there are at least 2 or 3 more that can't agree. And realistically, if there are 3 or 4 powers of attorney established, all medical power of attorney, where all of you have equal say in what happens next, and you don't agree on what happens next, mom's care might suffer, or mom might progress to a point where she can't get help anymore while you're arguing about what's right. And that's a terrible place to be in. And so, of course, in the best case scenario, we all agree, we get on the same page, and we make those decisions quickly and easily. But in the real world, sometimes we have to be prepared to have a point person who can make that decision and certainly take other people's feedback, but ultimately be willing to, potentially be the bad guy, or potentially just be the voice of reason and say, I'm sorry, this is what we have to do, and we have to do it quickly so that mom can get the help she needs. And so that might mean, even though there's many of you, establishing one power of attorney. Some families, what they do is they establish a pattern. So it's, the oldest sibling is the power of attorney, or the sibling with nursing experience is the power of attorney. But if that person is unavailable, or God forbid something happens to them, then this is who's next. And then this is who's next. And you can specify things like that in those documents so that there is a hierarchy, but still everyone's involved. And that might be a good middle ground to consider. But these are the challenging conversations that you have to have. We also want to think about, how do you feel about routine or less invasive treatments? So this is dental care, at the point that our loved ones are old, maybe they've got dentures, maybe they don't care anymore. Maybe they take a lot of pride in their teeth and they still want to go to the dentist twice a year. Dermatology appointments, if they develop, a mole that's changing, or a lesion that wasn't there before that's potentially skin cancer, do they want to let it go? Do they want to have a quick 20-minute outpatient procedure to lop it off and cut, and cut their losses so that it protects them? Mammograms, colonoscopies, routine testing such as that, even for a person with a healthy brain, those things are a pain in the butt. And so for a person with dementia, particularly as their dementia progresses, they may not understand the need for that testing, especially with a colonoscopy. They may not understand why they have to do that prep work, and that prep work can be very stressful for them. It's not pleasant for any of us. And so that might mean that it's not worth it for some of them. And that might depend on factors like family history and things like that. So definitely conversations we want to have. How do you feel about life-saving or invasive treatments? This is your surgery, your CPR, your feeding tubes, your intubations, things like that. And so this is an especially difficult conversation for a lot of people, because you might think, well, if they find me unresponsive, of course I want them to do CPR. But what that looks like in your 60s or 70s when you're having this conversation might be different than what that looks like in your 80s or 90s, where it may actually be happening. And so, the reality of the situation, let's say your loved one is in a care community or a nursing home, and the nurses find them unresponsive and they initiate CPR, they're going to break ribs. And even if your loved one comes back, they're going to have to live with the pain and discomfort of those broken ribs and the complications that that presents. And is that what they want for their lives in their 80s and their 90s? You know, and so there's a lot of shades of gray that we have to make sure we're discussing. What preferences do you have for your passing? And so I touched on this a little bit. And, you know, is there a funeral home you prefer? Is there a place you want to be buried? Would you want to be cremated? Do you want your services to be public or private? Do you want to be an organ donor? And particularly in the case of dementia, do you want to be a brain donor? You know, that's a weird question. But we need more research about Alzheimer's and dementia of all kinds. And unfortunately, the way that we do that is by studying the brains of people that have passed away very often. And so, is that something that they want? Is that something that you as a family prioritize so that future generations can hopefully have a better go of it? You know, and that's a weird conversation to have. And if that's something you're entertaining, how does that impact your desire to have, say, an open casket funeral or something like that? So those are things that we need to consider and discuss. And with some of these conversations, we want to make sure that we plan a timeline for reassessing those decisions because feelings change, you know? So, as I said, what CPR looks like and means in your 60s may be different than what CPR means in your 80s. And so, 20 years is maybe a long timeline, but maybe every, year, couple years, you want to check in and say, hey, this is what you said last time. Do you still feel this way? Or if your loved one is no longer able to participate in that decision, talking with your, siblings or other family members and saying, hey, this is what we decided on last time. Do we still feel this way? Do we still feel that this is what mom would have wanted or what dad would have wanted? So the power of paperwork. So these are those legal documents. And just so we're clear, this is not an extensive list. This is just the three most common documents that we see for our residents with dementia. This is not intended to be legal advice. This is just a quick, these are what these documents are. This is why they're important. Make sure you go talk to an attorney about getting them in place. Kind of a thing, if that's right for you. So the basics, the power of attorney. This is definitely something that you want to establish early in the dementia process so that it's in place at a point where your loved one needs that support. It designates someone who can receive medical information. This is a medical power of attorney, who can receive information. So we all know about HIPAA, that our privacy is protected. Doctors and hospitals will only release information to people that are very specifically designated by the patient, by your loved one. So the power of attorney entitles you to receive that information in the event that your loved one isn't able to say, hey, this is my daughter, or hey, this is my son, and I want them to have it. So that's really important because if, mom or dad goes to the emergency room and you're in the waiting room saying, I need to be there to help them, and they're saying, sorry, we don't have you on the list, then mom or dad is struggling by themselves in a situation they may not understand. And that's really bad. So this is something that we want to have in place ahead of time. So at minimum, it entitles us to receive that information. And it entitles us to make decisions for them at times when they are not able to do so independently. And so this is a big thing and a common misconception for powers of attorney. It does not mean that your opinion overrides mom's or dad's, as long as they are capable of making that decision on their own. So they are alert, they are cognizant, they are participating in the conversation with the doctor, they are allowed to make their own decision. It just means that if they are not alert, maybe they're asleep, maybe they're unconscious, They're not cognizant. They don't understand what the doctor is saying. Maybe they're overwhelmed. Maybe they're confused. That's when it gives you the power to step in and make that decision for them. With people without dementia, this is often much more straightforward. So for our loved ones, this is a lot more complicated because whether or not they're alert and aware and cognizant might be different from day to day, might be different in this time of stress than it would be on an average day when they're not having a medical problem. Might be different from one hospitalization to the next. Maybe it's been a while since the last time they were hospitalized, and last time they could handle it and this time they can't. And so when we think about whether or not they're competent to make decisions, whether they're capable of making those complex decisions, we really want to focus on where are they right now in this moment. And it might be helpful to check in with, a doctor, whether that's a primary care or a neurologist or whatever, semi-regularly, just to determine where their competency falls, so that you're not trying to make that decision in the moment, and so that you're not trying to convince the emergency room or the hospital staff in the moment. So then the next one is advanced directives. And this designates preferences for treatment and designates someone to make medical decisions in the event that the person is not able to participate, like completely not able to participate, such as, they're unconscious. This is your loved one that was found unresponsive. This is your loved one that's under anesthesia. This is your loved one that's just completely lost, very confused, whether that's permanently or because of the stress of the moment. And so these are often decisions that are made well in advance. This is, do we agree to CPR? Do we agree to intubation, to ventilation, to feeding tubes, to some of those more unpleasant and invasive treatments that, yes, can save lives, but can also have pretty serious complications. And so these are decisions that we want to weigh the risks of well before we're in the heat of the moment, ideally. It's important to know that advanced directives do not necessarily follow the person. So you might think, okay, well, mom broke her arm and we gave them a copy of her advanced directive, in June of last year. And now we think mom might be having a stroke and we're back and they already have it on file. They likely don't. And if they do, it may or may not be out of date if you've updated preferences since then. And so because of that, you want to make sure that if there have been any changes made, that you always have a copy of the most up-to-date one with you. You want to make sure that you're giving updated copies to mom or dad's providers as they happen, along with written notice that the old one is no longer effective. And then the last one is the POLST, the physician's order for life-saving treatment. So if your loved one lives in our community, you're probably familiar with this. We use them religiously. So this is not technically a legal document. It's a physician's order, just as it says in the name. So this is a medical order that is being signed and put in place almost like a prescription, except a prescription for what's to be done next. And it does follow them. So your loved one's primary care doctor would write this, and it would follow them, and it does supersede advanced directives and things like that. So this is often much easier to update. Not always, of course, there are always, exceptions to every rule. But it specifies, what the person wants. And this is something that places should be keeping on file. It still is something that you want to keep a copy of. And again, if it's been updated, making sure you have the most up-to-date copy in case your loved one's providers or the hospital is holding on to an old one. Okay, so when emergencies arise, realistically, we don't plan for things to go medically sideways. There are going to be emergency room visits, whether that's, mom or dad fell and hit their head, broke their hip, whether that's like, oh, their blood pressure is weirdly low or weirdly high, and we need to get that checked, whether that's they have a cut that won't stop bleeding and we're not really sure what's going on there. More often than not, medical changes are happening like out of the blue. And so if we want to be prepared for when that happens, we want to make sure we have an emergency kit packed. So that emergency kit, and again, this is dependent on what's right for you and your family, but it should include updated copies of any of those legal documents we discussed. If you have them, they should be in this emergency kit, so you can just grab it and go. You might want to keep multiple copies, or encourage doctors and hospitals to make a copy for their records and give you back the originals. That way you aren't constantly chasing down more copies. It should have an updated medication list. You might want to keep any contact information handy, both for your loved one's providers. So if they're going to the emergency room, you want to make sure they know this is the care facility where they live. This is her primary care doctor. This is her neurologist. This is his orthopedic surgeon. This is his, oncologist if he has cancer, things like that, so that they can collaborate with those providers if need be. Also, contact information for any other family members, especially if you're not able to be there at every moment, or if there are other family members designated to be involved. Make sure that that contact information is on there so that you can just hand that, one piece of paper, whatever, to the hospital and know that it's taken care of. If your loved one does live in our community, we send all of this documentation with them anytime we send them to the emergency room. However, just because we give it to the EMTs does not mean that the EMTs give it to the emergency room doctors, or if they do, it doesn't mean that the emergency room doctors pass it on to the admitting doctors if your loved one is admitted. So even if they're coming directly from a facility like ours, you still want to make sure you're prepared with these, with these documents, because just realistically, a lot of times we see that they don't follow the person through the process. Same is true for copies of identification, insurance cards, things like that. Your Medicare card, Medicaid card, any prescription plans, things like that. You want to make sure you've got copies of those for them to keep on file that are up to date. Changes of clothes. Obviously the hospital is going to provide gowns for our loved one that's in the hospital, but if they don't have procedures that require them to stay in the gowns, they might be more comfortable in their own clothes. You also might want to consider packing changes of clothes for yourself, especially if you're planning on staying at the hospital with them for extended periods. And that's also going to include, essentials, incontinence supplies, adaptive equipment, their cane, their walker, their wheelchair, their glasses, their hearing aids, the charger for their hearing aids, things like that. You want to make sure you've got on hand, and phone chargers and things like that for yourself as well, because if you're going to be at the hospital for a while, you're going to need that stuff. We need to be prepared to advocate. Our loved ones at this point often are confused and distressed and may or may not be able to speak up for themselves. That's your role. Speak up for them. Be their voice at a time when they can't be their own voice. And as much as we like to view doctors as professionals and experts, and we trust them, and we do, absolutely trust them, they don't necessarily have the long-term perspective that we do. The hospital, by definition, is trying to stabilize the emergent medical need. They are not necessarily thinking about what those stabilization efforts mean once mom or dad returns home. And that's an important place for you to be the voice. So just some common things that I see. This is, again, not an exhaustive list, but some common issues that I see where the hospital may not recognize that there's long-term complications to this: medication changes, physical or chemical restraints, and disagreements about admission and the discharge. Okay, so when I say medication changes, this might mean they're discontinuing a whole bunch of mom or dad's meds, which is fine if there's a good reason for them to do that. You want to make sure that they're informing you as to the why of all of those changes so that you can weigh the risks and the benefits. Okay. It may mean that they're adding medications. And again, you want to understand why they're doing that. And you want to be mindful of medications that are intended to have calming or sedating effects. So, unfortunately, what we see a lot for our residents with dementia, especially those that tend to be restless and tend to do a lot of wandering, is that behavior is very concerning for the hospital staff. They do not want them getting out of bed. They do not want them walking around. And so they're going to give them sedatives or medications to calm those nerves to reduce the likelihood that they're going to get up unsupervised and potentially fall. Now, that sounds great in theory, but when we hear words like Haldol or Risperdal, really potent sedating psychiatric medications, the hospital is focused on the immediate impact of that drug. I'm going to put mom on a Haldol drip. She's going to go to sleep. She's not going to walk. You don't have to worry about her falling. She's going to be more cooperative with procedures. And maybe that's necessary for what's happening. But what the doctors in the hospital don't see is that it's going to take 2 to 3 weeks for that medication to get out of her system when she returns. And so when she comes home and she's no longer receiving that medication, but she's still woozy and groggy and confused and off balance because of it for weeks, is that going to be a problem? Does that risk warrant that benefit? And that's a case-by-case basis that you have to make in the moment. Unfortunately, we've seen a resident go to the hospital for something, receive the Haldol, receive the Risperdal, receive some medication like that to keep them calm so that the doctor can do what they need to do. And then they come back to the community and they fall and they break a wrist or an arm or a hip because their balance is off and they're not really paying attention to where they're going because of the lingering effects of that medication. And then we're right back where we started, back in the hospital. So something we want to be mindful of. Physical and chemical restraints. So chemical restraints is exactly what I'm talking about with those strong medicines that are intended to sedate them so that they're more cooperative. Physical restraints are also sometimes necessary. If your loved one is going to try to pull out their IV, going to try to pull out their catheter, you may see that the hospital will use soft restraints to literally tie their arms down. You may see that if your loved one is continually getting up and falling, that they may use soft restraints to keep them in the bed. And again, I'm not saying this is right or wrong. It very much depends on the situation. But every day that our loved one spends in bed without being able to move, it equals a number of days, weeks, sometimes even a month, that it takes them to regain that mobility. And so if they're being strapped to the bed because they're doing this dangerous thing, does that mean that they're not going to walk again when they're discharged? And is there a middle ground there? Can we, restrain them for part of the day, but allow them to walk with support for part of the day? And how frequently is that happening and who's responsible for that? And those are conversations that we can be having. So we need to make sure we're prepared to advocate for our loved ones in that, in that regard, because the hospital, again, is focused on this isolated incident. And this isolated incident is important and their perspective is important. But your responsibility is to think about mom's or dad's whole life and what it's going to look like when they come home from the hospital as well. And disagreements regarding admission and discharge. So sometimes we see that hospitals want to keep people for a really long time. If they're being vague about admission criteria, if they're admitting your loved one because of a diagnosis you already know exists, like dementia, that's probably a sign that they don't really need to be there. And it may be that they've got other things they want to monitor, and that's the best way that they can justify it, and that's fine. But it may be that their census is low and they're trying to make some money, and that's less fine, So we need to be challenging those decisions. More often, what we see is that hospitals want to turn around things quickly. And so we might feel that our loved one needs more time, and they're saying, nope, they got to go home today. This is especially true if your loved one has been restrained in the hospital, if your loved one has been receiving one-on-one care in the hospital, and the hospital is eager to get them out because those things are demanding of resources and, time and money and people. But your loved one is still going to need those things when they come out of the hospital. And you need time to put that in place. If your loved one needs one-on-one care, you need time to find somebody to do that. And you might need time to find the financial resources to afford that, because one-on-one care is not cheap, things like that. And so, maybe your loved one needs rehab. Say they went in because they broke a bone and now they need, they had surgery and they need rehab. You need time to find a rehab that works for you, that you're comfortable with, that your loved one is going to be comfortable with. And that takes some time. You want to be able to check it out first. If they're saying, well, sorry, this is the one we picked and mom's leaving in an hour, you need to be prepared to speak up and say, hold on, we had a bad experience there. We don't want to go there. This is where we're focused, kind of a thing, and be able to speak up and be comfortable speaking up for what's good for mom or dad in the long run. And then some personal considerations. So this is just to make your life easier when emergencies arise. Again, by nature, they tend to be unpredictable. And so there might be some things that you want to think about having in place to make your life easier if you need to be present with mom or dad for an emergency. So one of the things you might consider is who is an alternate person or alternate people who can be available. Let's say you get the call, mom's on her way to the hospital, and you have a really important work meeting today, and you can't leave, at least for a couple of hours, but you want to make sure mom's not alone during that time. Who are you going to call to go meet her at the hospital? Who is going to be available to step in when you can't until you get there? Who's going to be available to stay in the hospital with mom when you really just want to go home and get a shower in your own bathroom? You've been there for a couple of days, you're ready to go. And that's okay. Who is that person, or who are those people that can switch places with you to give you a break? You might want to consider intermittent FMLA, especially only if you're working. If you have the luxury of being retired, this is different. But we do see some families will reapply for intermittent FMLA every year so that they know their job is protected if mom has an emergency or if dad has an emergency. And this just means that you go about your life, but when the call comes that mom is going to the hospital and you're going to be out of work for at least that day and likely a few days, you have that coverage that says my job is protected. You can't punish me for this, so that's one less worry on your mind when the time comes. If you have children or pets, or if mom or dad have pets, who's going to take care of them while you're in the hospital with your parent? You can't leave the kids unattended. You can't leave the dog to fend for themselves. If you do, you will regret it when you return home. And so who's going to be the person that steps in, make sure they get fed, make sure they get to school, make sure the animals go out, all of that sort of stuff. And you may want to consider a phone communication plan. This is especially true if you have a large involved family. You may or may not have the time and the energy to call all 5 of your brothers and sisters and all of your cousins and all of your aunts and uncles and let them know what's going on with mom. If you can do that, power to you. But more likely, if you're involved in keeping mom calm, keeping dad calm, talking with the doctors, talking with the nurses, figuring out what's going on, you might instead want to have a point person or 1 or 2 people that you are relaying the information to as you get it, and then have them be responsible for getting that information out to the rest of the family, just so that you can be focused on the task at hand, which is being attuned to the care that's happening and being attuned to mom or dad's emotional needs in that moment. When we think about surgery or other procedures, this is a big one. Whether this is an unplanned surgery, like a fall with a major injury that requires surgery to, set the bone, make sure it heals, or whether this is a scheduled procedure, maybe a cardiac catheterization, maybe, a lumpectomy or a mastectomy or something like that. If our loved one has cancer, things like that. Factors that might impact our decision making. And so just to be clear, I'm not saying it's right or wrong to proceed with surgery or to skip surgery. There are residents and families where the surgery is right and appropriate. Go for it. There are residents and families where the surgery is really not worth it and is going to create undue hardship and maybe make things worse. And that's the right decision. And there are lots of gray areas where it could really go either way. So these are just things that you want to think about to help you make the decision that's right for your loved one and your family. So one thing that we want to consider if we're on the fence about surgery is this an inpatient or an outpatient procedure? If they've broken a hip, that's an inpatient procedure. It's going to require anesthesia. They're going to be in the hospital for at least a couple of days. They're going to need rehab afterwards, that sort of thing. If this is, that mole on mom's cheek is looking a little funky, and the dermatologist is going to lop it off and biopsy it, that's an outpatient procedure. It's going to take 20 minutes. It's going to be a local anesthetic just to numb the cheek before they remove it. That's a whole different animal. So this is something we want to think about. Is this emergent or is this planned? Planned procedures have the benefit of giving us lots of time to think about it and to, make a plan to make it work. So planned procedures, this might be, again, cardiac catheterization, oral surgery, where you're booking it a couple of days or a couple of weeks in advance. If mom or dad needs a root canal, how are we going to prepare for that? Versus that emergent procedure, like, oh my gosh, they're having, a stroke in this moment and they need a brain catheterization to help improve their blood flow or something like that, where there's a lot more on the line. And is this a right call? Is this a one and done procedure or a recurring one? Again, oral surgery, sometimes it's a multiple process. If your loved one has several teeth that need to be removed so that they can be better fitted for dentures, oral surgery is painful and complicated. And if your loved one is confused and combative or resistant to having somebody with their fingers in their mouth, it may or may not be worth it. Maybe you let them just eat soft foods and keep going with the teeth they've got for a while. Or maybe they really don't like soft foods and you need those dentures and we've got to push them to go forward with it, that sort of thing. Or is this a one and done? Is this an in and out, regardless of how long the stay is required? This is a surgery we're going to do once and it's going to be taken care of. That impacts our decision making. The type and duration of anesthesia and pain management required. Anesthesia is a very complicated subject for people with dementia. For a normal, healthy brain, it can take as long as a month for every hour of anesthesia you received to clear that anesthesia fog. Some people bounce right back and feel great immediately. Other people will have a 3-hour procedure and they'll complain of brain fog and feeling a little confused and muddled for months afterwards. It's different person to person. Dementia complicates that. For a person with dementia, that timeline is longer. Those impacts are more dramatic. So it's not just the general brain fog, it's increased confusion. It might be decreased functioning. And is that worth the benefit we're going to get from the procedure? Is it worth the benefit we get from the procedure if the anesthesia confusion never clears? Because sometimes the brain does further decline in that time, and we don't see our loved one bounce back after a few months. And so that's something that we need to consider. Same is true with pain medication. A lot of pain medications come with side effects, constipation, fatigue, nausea, things like that. If our loved one already has irritable bowel syndrome, already has GERD, already has problems with, other things, is that pain medication going to make it better? Is it going to make it worse? How manageable are those side effects? If it's going to make them wobbly and groggy, is that making them more prone to falls and additional injuries? And how are we going to manage that? Do we need occupational therapy? Do we need to introduce a walker? Lots of questions that need to go into this. What does typical recovery look like? Okay, and typical recovery, again, for a person with dementia and a person at advanced age is not the same as typical recovery for a person with a healthy brain, not the same for a person 20 years younger. So we want to make sure we're taking their age and their cognitive ability into consideration when we think about what recovery might look like. Insurance coverage. I hate to say it, but realistically, if you can't afford the procedure and the aftercare, that might be a factor in your decision-making process. And that's a terrible thing to say, but it's the reality of our healthcare system sometimes, and the reality of our financial, position sometimes. Rehab preferences. If this is a major orthopedic procedure, back surgery, hip surgery, arm surgery, things like that, shoulders, whatever, mom or dad is going to need rehab for anywhere from a week to a month, maybe more, following that procedure. Is there a place you want them to go? Is there a place you absolutely do not want them to go? Is rehab going to be challenging for them for other reasons? Are they able to benefit from things like physical therapy if they're too confused to participate and if they're not going to remember what's asked of them? For some people, particularly in the later stages of dementia, rehab is adding an additional transition. So now we've said they've moved from home to the hospital to the rehab, back to home, or to a care facility, and each of those moves is having an impact on their confusion, on their cognitive ability, and making them more distressed. Is that stress worth that placement? Something you've got to weigh. Long-term health and cognitive consequences. So again, I mentioned this with the anesthesia, but sometimes during these periods of intense stress, during these periods of intense confusion, the brain does decline and may not bounce back once the situation has resolved. Is that a risk we're willing to take? And is that worth the discomfort that mom is going to be in or the dad is going to be in if we don't proceed with the procedure? And we want to consider their age and ability level at the time of the procedure. Realistically, what is my loved one capable of? Okay. There are times where maybe heart concerns or other health concerns mean that putting them under anesthesia may mean they don't wake up. Is that worth the risk? It might be the recovery and whether or not they're capable of that. Is my loved one capable of participating in physical therapy? Are they capable of benefiting from it? Is the strength building enough? Are they going to remember the strategies they talked about using? Are there supports in place to remind them of the strategies that they were supposed to use? So what are they capable of? If your loved one was wheelchair bound prior to surgery, odds are good they're not going to magically walk again after a little bit of physical therapy. Stranger things have happened, but we want to keep that perspective, that reality groundedness. And also, what will my loved one realistically comply with? Our loved ones across the board, regardless of dementia, can be stubborn. Dementia certainly makes them double down in that regard in a lot of cases. And so it might be that they're capable of physical therapy, but if they don't want to, you're not going to get them to do it. And a lot of places aren't going to force them to do it. Just, for health reasons and liability reasons, they're not going to force your loved one to do something they're saying no, no, no to. And so is it worth the time and the effort and the energy and the conflict? If you're arguing with mom or dad constantly to get them to do something they're just not going to bend on, and that might influence your decision making as well. And the last one, end of life planning. This is hands down the hardest one. So when we're thinking about end of life planning, again, we're thinking about those DNRs, DNIs, DNHs. Do not resuscitate, do not intubate, do not hospitalize. We want to make sure when we're thinking about putting these rules in place that we're considering how feelings or preferences might change depending on the timeline or the situation. There was recently an issue with a family where the loved one who did not have dementia updated their preferences to reflect a do not resuscitate, and then went on a walk and passed out on the walk. And while they were unresponsive, their child, who didn't know they had done that, performed CPR. When that loved one got to the hospital, they were alert. They were able to participate in the conversation with the doctor. They still needed more care. And in that moment, they had said, weeks prior had said, do not resuscitate me. But in that moment said, I'm not ready to die and I do want to proceed with these procedures. And so the complicated nature of the situation then is, while that person's alert and able to say that, great. But what happens if that person loses consciousness again? And now the legal document overrides it. And that's a really hard position to be in. And so we might want to consider, sometimes we put these things in place well in advance of when we need them. And then if something happens unexpectedly, it's like, oh no, we meant that when mom or dad is much more frail than this, now they have a lot of good years left, we want to proceed with it. That's not what the legal document says. So we have to be mindful of that. And the same is true of the flip side. If mom or dad is a full code, meaning they want every possible life-saving measure to be taken, or you want every possible life-saving measure to be taken for them, that might look different when they're, in their 70s and in relatively good health and mobility, and they've got a great quality of life. That might look different in their 80s or their 90s, where CPR means broken ribs and intubation means that their throat is going to be raw and sore for, days or weeks, where feeding tubes might mean that they're not able to eat solid food anymore. And if they were a person who loves food, is that going to be an unacceptable lifestyle change to them? things like that. So it's a very complicated situation. And when we're making these decisions, we want to make sure that other family members are aware. So kind of as I mentioned in the beginning, often we want to designate one or two people or have a hierarchy to who's designated to make those decisions and be involved in that decision making. And that might be hard for other family members to accept. We should be having those conversations whenever possible ahead of time so that they're not becoming an argument in the heat of the moment. Skilled nursing care. So these are things like IV treatments, wound care, when your loved one needs significant support just to get through the day, help getting dressed, help getting washed, help eating, help, making their meals, whatever that may be. When they need assistance of other people, sometimes multiple other people, just to get in and out of bed or up and down out of a chair. If they need extensive medical technology to get them through their day, maybe they need a lift, a mechanical lift to get them up. Maybe they need, oxygen throughout the day. Maybe they need 24-hour care. Is that something you can realistically provide in their home? Is that something, if they're in a care community, that their home offers? Is that an extra service you would have to add and pay for? Does insurance cover that? Is that something they even want? All those things are things we need to talk about. Palliative care. So palliative care is a great add-on service. It has a focus on quality of life. So primarily its concern is pain reduction and distress reduction. That's often happening through medications. Sometimes that's happening through supplemental therapies like pet therapy, music therapy, massage therapy to help with pain. Things like that are wonderful. Sometimes they offer companionship. It's a great add-on to make life more comfortable. And so it's important to know that palliative care is something that can be implemented pretty much at any time for any duration of time that the person needs to manage that discomfort and distress so that they can have a better quality of life. That's different than hospice care. A lot of the services are the same, but hospice care provides an extra level of support. Again, with that focus on quality of life and comfort at the end of life. So it also includes pain reduction and distress management, counseling, spiritual counseling, not only for your loved one, but also for you as their family, having a hard time with the reality that you may need to let them go soon. They may include those supplemental therapies, that pet therapy, massage therapy, art therapy, companionship, pastoral services to help with spiritual guidance through that time, additional support to help make sure they're clean and comfortable and cared for throughout that time when they may be harder to care for because, they're weak and they're passing and they're not as able to move and to participate as they once were. So this is a really great service. Sometimes we see that families are hesitant to implement hospice care because either of the fear of this makes it real. If I get them hospice care, it means I'm admitting that they're dying. Or because of a belief that in some way you're wishing it on them or making it happen faster. If I put them on hospice, it means they've got 6 months or less to live. That's not true. So I've seen residents that are on hospice for a matter of days before they pass, but I've seen infinitely more residents that are on hospice for months or even years before they pass away. So that idea that we get in our head of the 6 month or less timeline is really based on how frequently they need to be reassessed to make sure that they continue to qualify for hospice services. Maybe your loved one is going through a really difficult time, and we implement hospice services in case the worst happens. And those additional supports allow them to be less stressed and more comfortable so that their body can heal And we find in 6 months when it's time to reassess that they don't need hospice services anymore. That's a best case scenario. I know with both of my grandfathers, so one was in stage 4 bladder cancer and stage 4 kidney failure, and they told him he had about 2 weeks to live, and he told them to go to hell. But they implemented hospice services, and he refused dialysis, refused any treatment, but he was happy for the comfort medications and the comfort measures that they took. And he lived 3 more years after that. Just too stubborn to go. He said he wasn't ready, and he was right, but putting hospice in place meant that he was more comfortable at a time when he really should have been in a lot more pain because of that kidney failure and because of that cancer. And so it was a great comfort to him. My other grandfather, different situation, but he had gone through a period where he had pneumonia and was hospitalized for it 3 or 4 times in the same year. And so we started to consider hospice at that time. And then he bounced back. And again, a couple more years of good quality of life where he didn't need hospice supports anymore. So where one grandfather remained on hospice throughout, the other one came off of hospice and then later went back on it when a different health issue, reared its head a few years later. So I don't want you to let fear of what it might mean or how scary the language sounds stop you from doing something that can be really beneficial for your loved one and for your family. And the only way for you to know and to make that decision is to meet with the hospice professionals and find out what they offer and see if it's right for you. There's no harm in meeting with them and just seeing what feels good and what doesn't. And if you decide that it's for you, great. And if you decide that it's not for you at this time, also great. But information can't hurt. And again, comfort is the focus. Comfort for our loved one is the focus. So that's something that we want to consider. All right, I hope that this answered a lot of your questions. I hope that it gave you some guidance that can help you feel more prepared in the event that your loved one does have a medical emergency, or just to get ahead of medical planning for even routine procedures so that you can make better, more informed decisions about them, especially at a time when your loved one can't participate in those decisions anymore. But if you do have any questions, please reach out to Pam Garofolo. She is our corporate director of Tapestries. So she's my direct supervisor. She is a wealth of dementia experience and education, both personally and professionally. She's a wonderful resource, and she's happy to answer any questions you might have. Her email contact is there on the screen. And so next month, our topic of conversation will be environmental safety. So these are things we can do to make small adjustments to mom or dad's living space that's going to help them be safer and help them be more independent for as long as possible. Just some minor tweaks we can do to make them have a better quality of life. And so thank you so much for joining me today, and I hope to see you at the next one.